My name is Jenny Baumgartner, and I am a health scientist at the NIH Office of Disease Prevention. I will be the moderator for today's session. So on behalf of the NIH Office of Disease Prevention, it is my pleasure to welcome you all to the Prevention in Focus webinar series. Our webinars feature talks from prevention science experts who are making advances in public health. The webinar series provides an opportunity for the broader scientific community and the public to learn about the latest prevention findings directly from expert voices across the globe. So today, the Office of Disease Prevention and the NIH Health Literacy Working Group are thrilled to welcome Dr. Cathy Meade and Dr. Clemente Gwede from the Moffitt Cancer Center to present Say Yes to Health Literacy in Cancer Prevention and Control. Dr. Elizabeth Sarma from the National Cancer Institute will introduce our speakers shortly. So before we start the presentation, I would like to go over just a few logistics and housekeeping for today's session. All lines will be muted upon entry, and they will stay muted throughout the session. There will be a question and answer session at the end of the presentation, so please submit your questions you have for our speakers to the Q&A pod directed to all panelists. You can find this Q&A pod by clicking on the three dots next to the chat button on your screen. We will monitor these throughout the session. So please note that this webinar will be recorded and posted at a later time to the ODP website. So enough of that. I know everyone's very excited about today's presentation, so I'm going to pass it over to Dr. Sarma now to introduce today's speakers. Dr. Sarma, go ahead.
Thank you, Jenny. So it is my distinct pleasure to introduce our speakers for today's webinar. First, we have Dr. Cathy Meade. Dr. Meade is a nationally recognized leader in areas of health disparities, cancer communications, and health literacy, and research education and training. She has been a long-standing voice for recognizing the intersection of culture and literacy in cancer care. She was one of the earliest investigators to conduct studies whereby mismatches were identified between patients' reading levels and the reading levels of health information. As a member of the Institute of Medicine's Health Literacy Committee, she helped craft the 2004 report titled Health Literacy, a Prescription to End Confusion. Her current research spans cancer prevention to survivorship and seeks to bring health information, services, and scientific advancements right back to the community in ways that are understandable, useful, and practical. A notable outcome of her work is the creation of the Tampa Bay Community Cancer Network, a community academic network which informs community-driven studies conducted in Moffitt's catchment area. Her research is based on a community-based participatory approach that aims to build trustworthy partnerships for improved patient engagement in cancer prevention behaviors, such as improved colorectal cancer screening. This involves creating, testing, and disseminating language and literacy-specific programs, interventions, and messages toward health equity. Similarly, it is my pleasure to introduce Dr. Clemente Gwede. Dr. Gwede is a public health and health equity investigator whose research is primarily fueled by community engagement, community academic partnerships, and health literacy-informed approaches to develop, test, and implement behavioral interventions for prevention and early detection of colorectal and prostate cancers to eliminate cancer health disparities and improve quality of life. His work has addressed health system, social, cultural, and behavioral determinants of health using multi-level and literacy-appropriate cancer screening interventions in safety net primary care clinics, such as federally qualified health centers. This research has been supported by grants from the American Cancer Society, National Cancer Institute, U.S. Department of Defense, State of Florida, Florida Blue Foundation, and other sources. He has published over 150 peer-reviewed articles in scholarly journals. So I want to thank you both for coming here today to share your insights with us, and please take it away.
Okay, good afternoon, everyone. I hope everybody can hear me well. It is a delight to be here, and thank you so much, Dr. Sarma, for the welcoming introduction, and especially to NIH Office of Disease Prevention and the Health Literacy Working Group to give us a platform today to talk about health literacy. Believe it or not, Health Literacy Month began over 2 decades ago, 1999, and it reminds me of the importance of moving forward with clear and understandable information, as well as making the healthcare system easier to navigate. So in preparing for this particular presentation, Dr. Gwede and I began to look at objectives, and we recognize that there's probably a variety of individuals who may be policymakers, educators, practitioners, or researchers. So we wanted to balance the presentation to give some broad perspectives about health literacy, as well as to dig a little bit deeper and give some application relative to a series of colorectal cancer screening studies. So one, to underscore the importance of health literacy for optimizing health benefits, really reinforce the value and the importance of community academic partnerships to further the communications. And then last, to really highlight the strategies of how we have infused health literacy throughout our program of research. We hope that during the presentation, we will renew and refresh your knowledge and excitement about health literacy, provide some interesting, some challenging perspectives, and reinforce the value of partnerships among all of the organizations that you all represent as we begin to tackle health. So I hope you're ready to say yes to health literacy. Keep in mind that our program of research is embedded within our goal of mitigating health disparities. And it reminds me very similarly to health literacy. There's no single cause and no single solution. And it really makes us think about health literacy from that perspective, that it is multidimensional and multifaceted as we move toward our goal of achieving health equity. So as you begin to think about health literacy today, think of all the words that might come to mind, and it begins to remind us that there's really a lot to think about as we plan interventions, how we engage our partners, how we develop trustworthy relationships, how we empower individuals and communities with clear information. Also reminds us, as we look at these social determinants of health, that many factors play a role, such as in health disparities, but similarly also with health literacy, that we can't separate out a lot of these factors, and it's often very challenging and difficult to relate the uptake of a behavior to a specific health literacy intervention. It really is a blended aspect that brings all of these features together. And I think that's where we're at in the field of health literacy, that we're moving from that individually driven perspective to more of a systems organizational perspective. Now, keeping in mind that almost 2 million people will be diagnosed with each year, we know that cancer prevention is a great tool to reduce people's risk and lower the risk of cancer recurrence and improve treatment outcomes. With that, CRC, colorectal cancer, remains the second most common cancer of cancer deaths when the numbers for men and women are combined. The good news is that colorectal cancer can be prevented by regular screening, and that has been really the story of our research over the last decade. So today, as we move through the presentation, we'll be drawing upon colorectal cancer screening as an example, but keep in mind it would apply to many of the fields and disciplines and disease sites that many of you may be working in today. While we know prevention offers a cost-effective long-term strategy for the control, policies and screening programs are severely needed to raise the awareness and to reduce exposure to cancer risk factors. And certainly during the last COVID pandemic, we fell off on some of those screenings, so we have time now to catch up. But what is needed? Information and support. As you look at these graphics, is the information accessible? Is it clear? Is it complex? Or if you look at the picture on the right, which is taken from our farm worker community just south of Tampa, can individuals readily access information if they're from a rural setting? Also consider the changing health literacy landscape that really is a backdrop for all of our interventions. Rapidly changing demographics, a very multicultural, multiliteracy, demographically changing environment. Think and consider the social internet network penetration, which has exponentially increased over the years, and the healthcare and technological advances, many which are being derived at NIH and other many institutions around the country. Most significantly, we know over the past several years, this growing need to rapidly respond to information, to dispel myths, to correct information, and so forth. All of this greatly increases the literacy demands for all of us, not just individuals who may be lower educated or have limited literacy skills. Now, get your GPS out, because again, it does affect how we try and traverse through the healthcare system maze. Many factors, language, transportation, racism, biases, all play a role if we can begin to sort through and get to the information that is most relevant for our own situation. For those of us that know some of our work at the Cancer Center, we have often championed the efforts of not only looking at literacy, but also the influence of culture in cancer. And really, fundamentally, for effective communication, we need to attend to both and really look at how messages are created and that give context to the messages, relying on beliefs and values of the population we're trying to reach. Certainly, a number of great work has come out of NIH from the Office of Behavioral and Social Sciences Research that give a framework, a cultural framework for health as well, an important concept to think about as we approach literacy. Now let's get to the new Healthy People 2030 definitions, which really brings a lens as we celebrate Health Literacy Month. What you'll notice is that it has been split into two different definitions. The one, which is quite familiar, personal health literacy, the degree to which individuals have the ability to find and understand information. Then organizational health literacy, the degree to which organizations which can equitably enable individuals to find and understand information. So what's the bottom line here? This emphasizes people's ability to use information rather than just understand it. We want people and systems to apply the information. It focuses on making well-informed decisions rather than just appropriate ones. But clearly, this moves us beyond the individual where we've been for so many years and gives that equal attention, that deserved attention, organizational, healthcare, and governmental systems for accurate and accessible information. In short, it really expands our influence and really puts forth more efforts towards strategic and operational planning processes. What this really means is that multi-sectoral engagement is critical, and harmony among all the sectors, all of the sectors that all of you on this webinar represent as well. So certainly there are many pathways for communications as we look at health literacy, that if we have limited literacy skills, we may be less informed, less access to information or ability to get the information, which may diminish our self-efficacy. Put that in terms of entering a healthcare environment where power and privilege of medical terminology sometimes takes hold, it's often very, very daunting. I'm still a firm believer that all of us, no matter what our educational skills might be, are at risk for low health literacy once we enter the culture of the healthcare. Our goal is to connect culturally and literacy appropriate information to healthcare to improve access and acceptability, and to give it some context for the groups. So what have we done and how has this informed and shaped our research program here at the Moffitt Cancer Center? We created the Tampa Bay Community Cancer Network back in 2005, and we consider this our community academic model of engagement. Simply put, this is one of the early community network programs funded by the Center to Reduce Cancer. While the program started out focusing on outreach, research, and training, we've continued it through 2 cycles, and when the program actually sunset in 2017, it became institutionally supported and thrives by 4 working groups relating to screening, survivorship, youth, and HIV and cancer. What's important to take away from this slide, whereby we have about 30 community partners, where once represented 3 counties in our catchment area. We expanded that as the catchment area has increased to 7, 15, and even now 23 counties. But at the heart of what we do in Tampa Bay Community Cancer Network relates to our projects and our research studies, and you'll hear more about that from Dr. Gwede. And they simply start out with 4 pretty simple and basic questions. What are the community concerns? How is community involved? What and how do we do it? And then last, what are the outcomes? Early on, when we brought together a number of community partners and began to look at the health needs in the community, looking at the data, our community members told us, we've done a lot in the area of breast and prostate cancer. Let's focus on colorectal cancer. The data supported that, and they liked that approach because it affected both men and women. But clearly from the get-go, they were very concerned about health literacy, and that continues, 18 years later, to focus on clear messaging to get the word out in the area of cancer. What's common in all of our studies, and this expands and extends even beyond colorectal screening, community-based participatory research, the ability to engage community partners in defining the research question and working collaboratively as we design the study, recruit individuals, and guide and monitor and improve the study. Keen attention to social determinants of health, culture, and health literacy. Having a theoretical underpinning, in this case, the preventive health model, and all of our studies usually have a community advisory committee whereby members can provide their feedback, keep us on track for the most part, and take part and help with our formative research and in looking at the results. You will hear later that what we've learned from some of our studies is that easy to understand information is helpful, plus what we're finding is access to the fecal immunochemical test. But at the back of our minds is always the notion of what's the community benefit? What's the impact? And what all makes these ingredients come together is a highly engaged, dedicated, and a passionate community academic research team striving for mutual benefit. So as we think of this transformational community engagement, where does health literacy fit into all of this? Our goal is really creating new paradigms, unpack health disparities, but health literacy is one of the threads that goes into that. Where we've moved from descriptive, detection, and correlational studies, we're moving to interventional driven research. Some of my early studies, several decades ago, first looked at the readability of materials and the reading levels of patients. We've now moved into RCTs, and you'll hear later into implementation science studies. The goal is to invest in health and community literacy that aligns individual context along with community knowledge, skills, and resources. And this philosophy really marries very nicely and pairs with the new definitions of health literacy 2030 healthy people. Okay, this is the showstopper. I like to put this slide in, and anybody can put in the chat what they think this might be, where it might be, and how in the world does this relate to health literacy. Clearly, what is the recombobulation area? Well, for those of you that travel in the Midwest, if you travel in the Milwaukee airport, at the end of the conveyor belt where you've unloaded your sweaters, your computers, your mittens, your hats, and so forth, this is the area where you then begin to assemble everything back together. And similarly with health literacy, we're really trying to kind of peel and unpeel that onion and figure out what pieces will work the best as we deliver interventions. So this was your teachable moment for the recombobulation area when you go through airports. Actually, this word actually became one of the Jeopardy words in the last few years. So a new word for everyone. So let's talk a little bit more in the levels of health literacy, just in terms of background. And many of you may have different frameworks that are helpful to you in your endeavors and so forth. But we've been very drawn to the work of Donald Bean. Looking like the Maslow's hierarchy, it starts individuals and groups out at the basic functional level so that our messages can transmit basic health facts. And then we can move to more advanced interactive messages that engage providers and so forth. The bottom line is we want to move to the top whereby cognitive and social skills can be assimilated to critically analyze information, because the ultimate goal, we hope, is to move to action. Now, for those of you in the health literacy fields, you may ask, well, how do we measure health literacy? Believe it or not, there are over 217 literacy measures from the Health Literacy Toolshed. Here's just a sampling, and the ones highlighted in green are ones that we've used in our studies. I've used earlier the wide range achievement test, and the salsa is not a dance, but it is a derivative of the realm in Spanish. Just to give you a flavor of what these look like, and I present these so we also have some cautions when you think about the formulas and the measures, is that this is 11 items, 8 are scored, and if you score 6 or less, considering that you are at risk for low health literacy. Keep in mind, these are words. It only tells how people pronounce the words. It does not necessarily get at comprehension, a limitation. We're also drawn to, more recently, the single item literacy screener questions, especially the last question, how confident are you in filling out the forms by yourself? And this is really a subjective measure, and it seems to make people feel comfortable. So we're drawn to this one. And this last one, for those of you that are developing tools that are digitally, e-health literacy skill for electronic information may be helpful in your endeavors. So with that, we have many tools and techniques that we use in our studies, and I'm going to just highlight a few of these in the next couple slides. But most importantly, know who your audience is. Our audience is right there in Florida, which is a very diverse population, drawing individuals from all parts of the world. Encouraged to get the real mindset, the ability to create information that is relatable, engaging, actionable, and literacy friendly. And so as you can see from this that's just coming up, this is our Spanish language booklet on colon cancer. We've digitized it, and we can flip the pages, and this can be put on a patient portal and provide additional augmentation of information as well. Our projects are very systematic, and what you see here is just a sampling of some of our algorithms and design, moving from formative research, iterative pre-testing, to the development of the tools. But I call your attention to the most common reason that people may not take the FIT test. My doctor never told me. As we develop our interventions, we recognize that we can do construct mapping from some of the findings. And if I call your attention to the second one, literacy, patients were very unsure how they could use information and act on it. So we wanted to show how to assemble a fit kit in the bathroom and how they would then mail the kit. So all of those findings become infused in what we call our creative brief. Another tool that we've often used is transcreation, translating plus cultural adaptation, which really means simple translation is not enough, but through a very careful iterative process, we're able to take English language evidence-based interventions and move them to Spanish language. One of our favorite techniques is learner verification, and I think of this fondly because of the work that Leonard and Cecilia Doak, really runners in the area of health literacy, put forth in all of their writings and books. Simply put, we have a number of elements or items, as we call them. We begin a series of questions through short questionnaires to see if our messages are on track through a series, and we usually use at least 3 iterations as we develop the intervention. As you can see, our booklet moved as we tested out attraction from having several pictures to a very nice family-oriented picture, which was a result of our formative research. And again, you can see how we've tested out for comprehension, the before to after, and hopefully the visuals and the sharpness of the body parts became much more vivid. And there's our materials. And the last tool I want to share is deconstruction. We often deliver a fit kit to our patients in the community, and it may look like a simple envelope, but it has a little test tube, it has a red hazard sheet, a tissue, and one would think this might be easy, but what we've tried to do is to deconstruct the steps by actually showing it and actually having a portable little potty there as a teaching tool. So I have to tell you, our most popular health literacy teaching tool is the portable potty, where we can demonstrate. And so one wonders, could it be as simple as a portable potty? And perhaps we may not need printed materials. So with that thought, this is the cue for Dr. Gwede to get on cue for our colorectal cancer.
Okay, now to the story of CRC. And the story of CRC or colorectal cancer is straightforward. It is a simple one, and it's both simple and encouraging in the sense that colorectal cancer is preventable, detectable, treatable, and beatable, as you already heard in terms of screening. And we are fortunate to have modalities that are very effective at finding colorectal cancer early or finding polyps and preventing it from occurring. However, there are a number of challenges, as you will see. So we are also fortunate to have very clear guidelines as to who should be screened with what tests and beginning at what age for average risk individuals that do not have increased risk features such as strong family history. So there are 2 most commonly used tests in the United States, the endoscopy or visualization tools, with the primary and most thorough being colonoscopy, which can be done every 10 years. It's a 1-step test. And if you are clear with no polyps, you can repeat in 10 years. The other kinds of tests are the home stool tests, which are simpler, more available, and can be collected at home, sent to the lab. And that includes the fecal immunochemical test, which is the primary driver of our research strategies that I'm reporting on today. This Cologuard or stool DNA test is among those, but it's a little more expensive. At the end of the day, when a fit test or Cologuard is abnormal, you have to follow up with a colonoscopy and to see the sources of the problems. There is no evidence from randomized clinical trials that one form of screening is superior than others. They are generally home stool tests are comparable to colonoscopy when it comes to detection of cancer, but definitely not as thorough when it comes to finding polyps. So the best test in our mind and in our lab and in our mantra is that the best test is one that gets done because patients need options as they are receiving care in resource limited environments. So if a positive test or abnormal fit test is followed by a colonoscopy and linkage to care, which is the most critical part to do a follow-up colonoscopy and or provide cancer care if cancer is found. So I'm going to give you a very quick rundown of the studies we have completed today, the rationale for doing them, and some general findings that led us to move forward with the current R.E.A.L funded work. So this work started in community setting, and we were trying to answer the question, are the disparities we see among Black populations due to differences in how they perceive colorectal cancer? So we did that first study, and which led to the second study funded by the American Cancer Society, which was an intervention. So in the first study, we found that information that addresses common perceptions was adequate, and we could address unique features from different subgroups like in the same intervention. So in the IACT study, we recruited people in the community, gave them access to fit kit. The conditions were randomized to a photonovela booklet versus a CDC brochure. And the question was, does the type of information matter when access is provided? And I'll tell you the answer in a minute. And the second set of studies were done in federally qualified health centers, a series of 4 of them, starting with the development of the English CARES, colorectal cancer awareness, research, education, and screening, which was done under the CNPC center that Dr. Meade shared. We then followed that with transcreation to Spanish language, and then did a combined study, dual language intervention, also in federally qualified health centers. The question in the first 2 studies was, can we excite people to get screened initially? And we didn't ask a follow-up question. But in the third study, community case, we started getting to, if they are screened within initial fit screening, will they repeat the following year? And of course, we were trying to address concerns and barriers and impediments that drive our health disparities picture. The last study is a combination of the 3, which is implementation science design, no longer RCT, in rural and urban clinics, diverse population, multi-language, and using all the evidence-based components that we learned so far, using a champion, which translates to a coach intervention, but the champion is working across all the levels, as you see in a minute. We did this in federal qualified health centers because we realized the disparities and underutilization of colorectal cancer screening was greatest in that environment. And these were people who already had some access to care. So we wanted to really provide them an adequate avenue to be screened. Our results. And we had highly positive results or impressive results, reaching 80% in the first 3 studies when all intervention conditions are combined. And we did not see an intervention group difference in each of these 3 studies because, and we concluded that the type of information mattered less when access is provided. We exceeded 80% in every community target, 74% the Healthy People 2020 goal, and the national average at the time. In the 4th study, which was a beginning of a multi-level approach and a beginning of an implementation science, we found a lower rate of screening, and we thought those were because of several factors. COVID impact, which prevented people from returning the kits. The clinics used their own kit fit, not one that was provided by the study, getting us closer to a real-world implementation approach. And in-house clinic testing was part of the mix, and the patients were being asked to return the kit to in-person versus mailing back. So some of the lessons we learned is that we should provide options of returning the kit by mail. But this design was more real-world. So I want to cover a little bit of some comparisons of the 3 studies, and in the sense that we show here the English language CARES project, the Latinos language Spanish, Spanish language cares project and community cares dual language, and there were a high representation of Hispanic Latino participants, which was great, and addressed some of the diversity we were trying to look at. And we assessed health literacy with two different tools, the R.E.A.L and the single literacy. And as you can see here, the literacy rates were about a third of the population were classified as being at risk for low health literacy. And again, further comparison, we see that the intervention conditions achieved high uptake, and we see that there were no group differences, as I mentioned earlier. And we assessed whether there were differences in uptake of FIT based on levels of health literacy, and we found no differences across all three studies, suggesting that our materials were low literacy enough that everybody benefited. So therefore, we concluded that the type of material may matter less. Access to FIT seems to be the main driver of the high uptake. Now, we did also some additional analysis trying to look at the correlates of health literacy, low health literacy in particular. This is showing you one example from the CARE English study, where we have in here demographic factors and their association with being categorized as in low health literacy. And we find that male gender was associated, men were more likely to be in the low health literacy or at risk for low health literacy. And at the bottom of the slide, you see that education was also, people who had higher education were less likely and to be classified as low health literacy, which makes a lot of sense. And continuation of the analysis in multivariable correlates, in multivariable analysis, we found that there were 3 demographic variables and 2 social influence and religious health belief model, preventive health model factors that were associated. This aligned with our intervention materials addressing social influence and religious beliefs. So this informs intervention content. And last but not least, I wanted to give you a flavor of what the distribution of health literacy scores were in these different studies. Looking here at community cares, the dual language intervention, again in federally qualified health centers. And you see here in the 3rd column for the item at the bottom that is marked in red, the levels of health literacy across the total sample and by intervention arm. And what we concluded here was that the distribution was similar to what we saw earlier, and that the group that had very low health literacy is a small proportion. So if you look at the not at all category. So this again informs us about the importance of producing literacy fluent materials as a third of the population are in the lower category. These are the published manuscripts, a few of them, and you can look them up for the specific results. And so at the end of the day, what did we learn and what do we now know and what is next? So we learned at the individual patient level, as well as at the organizational level, that health literacy is important, and organizations are very conscious of that and are doing many strategies to improve the clarity and plain language aspects of the communications and information, written information. We also learned that our FIT-based interventions produce high uptake when coupled with education, FIT, reminders, all the best evidence we have from the literature. And access is important at the organization level as well. We found no differences in terms of intervention group effects, suggesting that our materials with bells and whistles did not exceed the simple brochure from CDC, and we think access to FIT trumped or depreciated those effects. We also found that individuals who received these interventions in the Spanish language seem to benefit more, as we found more FIT uptake in that group compared to the ones who received English language information. Ultimately, at the end of the day, we took all this evidence, this information, and the fact that our providers and patients preferred locally developed materials opposed to the CDC booklet because they found it to be relatable, engaging, actionable, and literacy friendly. So we moved this work forward to a multi-level, multi-language implementation science intervention with multiple clinics as you are, and coupled with a champion, as you will see next. So this is our current funded R01, of which, again, our program director is on the call, Dr. Erica Blaswell, in which we are implementing this intervention we call colorectal cancer awareness, research, education, and screening, rural expansion, access for health equity. And we wanted to accelerate the work we had completed to date by doing organization-wide different clinic settings and build on what looked like a sustainable model using a real-world design. The EBIs, or evidence-based interventions, included low literacy materials, feet, reminders, and a champion, again, as you will see next, who worked across the different levels to address barriers and facilitators for colorectal cancer screening. Our aims are as follows: to do an organization-wide intervention to assess the factors associated with overall fit and other colorectal cancer screening usage, and to conduct comprehensive evaluation of implementation processes to inform the scalability of this intervention. So this is the sort of the guiding principle. It's a multi-level study that uses a stepped wedge. The stepped wedge design is rolled out in 2 waves. The waves involved 7 clinics in each wave. The clinics were randomly selected and balanced in each group or each wave by rural urban status, population size of the clinic. And you can see, if you are familiar with the Tampa Bay area on the right-hand side, the counties in which we did that are those that are marked in green. And so there were 6 counties altogether, and the intervention is still ongoing. So this is the step wedge design with a little bit of an extension in the last year for maintenance. The key features of the step wedge include the year 0, where you do preparatory work and document all the status of the screening modality or topic of question, and then intervention that is rolled out in waves. Our waves were a year apart because we felt that the usual care would hold up during the delay years. If you look at the left-hand side are the components of the implementation, and to date, everything that is a check mark has been implemented, and we are starting to look at our surveys to understand how the application of the different implementation science frameworks and concepts may be affecting implementation processes. We want to point out that the champion or coach intervention is a critical component to this design or this intervention, and it will continue. These activities will continue for another year, and then we'll begin to evaluate in year 5, which is year 4 of the implementation design. So at the end of the day, what do we expect is the potential impact of the CARE Switch study? We want to improve community benefit by bringing greater access to clinics that would otherwise not implement such an intervention, using evidence-based components that I talked about. We want the study will enhance and expand and hopefully inform scalability to other federal qualified health networks in our catchment area and in the state and beyond. It bolsters our clinic capacity by implementing this cancer control champion, which is a role that works across the organization, down to the providers and at the patient level to facilitate discussion and follow through with screening uptake. Ultimately, we hope this improves performance measures for the clinics, such as the UDS measures that we talked about earlier. At the end of the day, integrating of health literacy strategies ought to be at the patient, the provider, and the system/organization level, as we know that multi-level interventions work better, produce greater synergy than client-directed interventions only or provider-directed interventions. So impact. So our bottom line message, say yes to health literacy. And before we go into questions and answers, and I know I covered this very fast, I wanted to acknowledge our funding sources for the different studies that we implemented over time, starting in 2010 to now, and also thank our Moffitt Cancer Center collaborators. And I want to point out that there are many postdocs who were trained during this period of time of 2010 to now that have left the program, and their names are not reflected here, but we appreciate their help. And then we have a number of community partners that participated in the different studies, and more partners, and the final slide with all our acknowledgement of our team members and collaborators and partners. I will stop here and answer any questions.
Okay, thank you so much, Dr. Meade and Dr. Gwede, and for your flexibility figuring out that technical glitch we had in the middle there. We got all the content in, so thank you so much. And the presentation was fantastic. So let's now move on to the Q&A portion of our session. As a reminder, it'd be great for you to submit your questions to the Q&A pod directed to all panelists, and you can find that Q&A pod after you click the three dots on the lower level of your screen. I did see one question come in to the chat earlier on, and let me go ahead and read it now, but get those questions in. What are some common reasons for those not taking or paying attention to screening tests? Could you share any trends or behaviors from different communities?
I'll begin with that by saying we did see different trends in different communities. The most important common reason that people give when a fit kit is actually delivered to them is that I forgot, I can't locate it, so we mailed them another kit in most of the studies, or asked them to come back to the clinic to obtain another fit kit. But occasionally we hear that people are concerned what they will find down the road. So our booklets address that. If the fit kit is abnormal, it doesn't suggest that you have cancer. It just means you need a colonoscopy to follow up. And if you can't afford one, you'll be assisted. So we see the typical reason. And then the last one clearly is always, well, the doctor didn't really explain it, yet they were assisted by another member of the staff. So.
And to add to that, I think, as Clement was mentioning, the linkage to care was a very important point, and that needs to be carefully worked out with the clinics you're working with, the cancer centers you might be at. So you've got that safety net in place, and the patients feel comfortable if they're going to get the FIT test, and then eventually if they have to move on to a colonoscopy.
Mm-hmm. And we thought we would find a lot of people who said, I didn't do the FIT because I prefer a colonoscopy. That was not a common reason that was given, but could be.
Great. Okay, another question came in. So in the era of patient portals and the immediate release of medical records in English and in complex medical terminology, how can we support patients with low health literacy and reduce disparities? Excellent question.
I think I'm gonna give it more value. I think the most important part is access to care, as insurance coverage, however way it prevails. With that, we can provide people options to go either on FIT first and follow up with colonoscopy, or direct to colonoscopy for everyone. That being said, we really need to map out the coverage if cancer is found, because that is a big question mark in people's minds. So it's not only for people with low health literacy, it's mostly for people who are underserved, uninsured, underinsured. Because I think the health literacy question in our studies has been shown that there is no differential for low health literacy populations versus high in the way our strategies were employed.
However, if we want individuals to expand their access to information, not only to individually help patients and community members with trying to understand patient portal, but the system, the organization can begin to implement teaching classes or some type of training to look at it more from a system perspective. And I think that really has been one of the areas that we've learned over the past decade or so, is that you can't do it just individually focusing on your patients. You have to engage the systems. And our federally qualified health centers that we work with are really quite excited, because this, if they can move their benchmarks for colorectal screening, that helps what they call the uniform data standards, and it helps their benchmarks from a quality assurance standpoint too.
Thank you. Another question. I think this one relates to some of the findings you presented. So this person would like you to please elaborate on the social influence, religious faiths, and gender, how these facets influence low health literacy in the results you presented.
Yeah, I don't know that they influence low health literacy. I think in our study they were associated, so we can't tell you the dynamics. However, having said that, how we use those findings is to begin to say, are these issues addressed in our intervention materials, or are these issues that we should think about when we pitch a screening discussion with a male patient who seems to be reluctant? Where should we begin? What are the talking points? So I think part of the challenge with assessment of health literacy in our research is that there are many tools, different meanings, but I think we should use the findings to see how we might do our interventions better in messaging for certain groups of patients. So I don't know whether they wanted me to explain the relationships themselves, but the point of our research is that when we do our intervention, we need to speak to the fact that you may think cancer is inevitable. However, there are ways you can take advantage of the screening tests we know are helpful, so that you can continue to help increase your protection against colorectal cancer. So we don't spend time trying to deconstruct their beliefs, but to leverage their beliefs to craft a message that is compatible with their thinking.
Great, thank you. I think we might have time for this question. This is a really good one about language. So this person really appreciated your discussion about expanding your work into different languages. They really appreciate the comments of the simple translation is really not enough. They're wondering how we can expand our work into other languages and how to reach diverse populations who speak multiple languages.
A great question regarding language. Again, knowing whom your audiences are, and in our area, there are three main languages were English, Spanish, and Haitian Creole. So I think once you sort of have that framework of what's in your geographic area, then you begin very systematically to take the information, the evidence-based intervention in English, and begin to translate and culturally adapt it. And be happy to share more information about the transcreation process and what that would look like, whomever submitted that question. It's difficult to take all of the information, all of the languages, because we know there could be hundreds in different dialects, but trying to hone in on the most common and then identify if there may be some other tools that might be helpful, like the porta potty or very simple diagrams and visuals that might help in that language, which might be more cost effective. I did see a question come through regarding insurance. Can we comment on that, Jen?
Yes, please. And then we'll wrap up after that one.
Okay, the question about insurance, I just want to make a comment, is that both the clinics, federally qualified health centers, as well as us as researchers, that is one of our prime concerns and worries, to be quite truthful. And so at the get-go, we very much carefully identify where patients can be navigated to. Certainly if they can be navigated in their own community, or if the clinics have their own endoscopists, that is helpful. But also if they
Looks like we lost your audio, Dr. Meade. All right, let's wait just another second, see if they come back on to finish that thoughts. And if not, maybe we'll just wrap up. Okay, so it looks like we're having some technical difficulties again. No problem. We're over time. There were a number of questions that we didn't get to, so I will circle back to our speakers and see if they will kindly answer those questions for us, and then we'll post it to our website. So just as we're wrapping up, I would like to thank our speakers one last time for their presentation, as well as all of you for joining us and for your engagement. A recording of this webinar will be archived and shared on our website in a few weeks. If you have any questions about the Prevention and Focus webinar series, please contact us on the email address on your screen, and the slides and recording will be available there at a later time. So thank you all again so much, and we'll see you again for our next webinar on December 19th. Please stay tuned for more information about that. Have a fantastic afternoon. Thank you so much.